I've said that to patients, okay, because it's a slightly different disease setting than breast cancer or colon cancer. And so in myeloma, that ISS system that I showed you is the only thing we have that's equivalent to stages. And like I said, I think the ISS system on its own isn't really very good for giving you any information. And so the way I approach it is to try and talk to patients about what's their kind of risk status. Do you have high-risk disease, middle-in disease, good performing disease, and how we're going to try and put the treatment together with the patient, because simply talking about the stage can frighten people. You can have ISS 3 and you can live for ages and ages. So for a sequencing panel, you need to be pre-authorized for it. So you just need to be careful before you sign up to it. But FISH is generally done, and we try and get some representation of the different FISH groups. So that's generally done in the academic centers. Yeah, so I'm going to talk a little bit more this afternoon that will probably go into answering some of that. But if you've got disease left in the bone marrow, I know Ravi does a great job, so he probably has a lot of information that I'm unaware of.
I think that, again, it's important to get diverse opinions. I think a lot of patients are on clinical trials, and those are trying to answer questions as well. So I think there's, not talking each individual patient, I think it would be inappropriate to do so in this audience. But I think that we're still learning, and there is a diversity of opinions you have to realize as well. And so certainly tailoring treatment to each patient is a goal. And we know that trying to get deep responses leads to better, meaningful outcomes for patients. What we are not entirely clear about, I think, is whether giving additional treatment to get to those disease responses will lead to better outcomes for each individual patient. I think that is the dilemma that we're trying to solve. So not to confuse people, what it means is that we know that if, say, a person has a deep response, is MRD negative today, he's going to probably do better than a person who's MRD positive. But what we still are not sure about is that if patient is MRD positive, if giving him more treatment and making him MRD negative, he's going to be doing better. I think that that is a thing that makes intuitive sense, but in other diseases has not worked out that way. So we need to get that information. So I think depth is important, but to keep it in context that that is not the only thing. And plus, as Gareth will probably tell you as well, a lot of work was done in Arkansas, that there's subtypes of myeloma that do just fine even when they have protein left in their blood, and it's not as simple that everybody has to get to depth.
Yeah, so I was gonna say that anyway. So there's one thing you shouldn't do, which is worry. There's 15%, that 11-14 group, the CD2 subtype, is a classic slow responder. You look early, you can frighten yourself and the patient, and it's where you ultimately get that's important. So there'll be other components of your treatment, and getting to MRD at some time, I believe, is a positive thing. But just because you aren't there now doesn't mean you won't be there in a year's time.
MRD negative, I think that today depends on whether you're MRD negative on treatment or off treatment. Obviously, whatever you're on treatment or off treatment, you would not probably want to do anything different if you're MRD negative. So I think that what we don't know is if you go from MRD negative to MRD positive and everything else is the same, whether even intervening at that time is going to be beneficial, or whether you should allow for a little more overt relapse, because you have to realize that any treatment does have some toxicities, and there's always a theoretical chance that you could be breeding resistance as well. So this is the million-dollar question that we're trying to answer and will be answered in the years to come, whether treating early for people who go from MRD negativity to positivity is going to benefit patients or not.
So we would try and assess everybody at presentation. The real world's not really like that, because maybe 30 to 40% of our patients pass through a community doc who's given them 3 or 4 cycles of VRD, and then there's nothing in the bone marrow to do this with. The MRD testing and the GP does work a proportion of the time, and I find monitoring MRD to be really helpful in the clinic. And there's a trend in doctors out there to say, you've hit MRD negativity, so we'll stop your maintenance. And I think that could be inappropriate. I think it's a marker of people who are doing well with the treatment, and you should probably continue for those. And for me, if you were MRD positive, I'd probably change the treatment to try and get people into MRD negativity. Ravi and I are two sides of the same argument. We both want data to make our clinical decisions. I've sort of taken a jump of logic and think that MRD negativity is somewhere you should go. And if you became positive, I would not wait for a patient to develop end organ damage because of the disease, because that seems bad to me, because it can enhance your risk of progression from that time onwards. But I think we're both on exactly the same page.
I've got 3 questions.
Let me just one other address. So this, sort of this gene expression analysis, I'm going to admit I oversimplified in the sense of looking at a proteasome inhibitor. Gareth is going to pat me on the back for admitting that. I oversimplified in part because I was looking at a response to a proteasome inhibitor and trying to predict a response from a non-response. And the fact of the matter is most patients are getting combination therapies. So you may have a fairly weak response to a proteasome inhibitor by itself, but when you add an IMiD and you add dexamethasone, now that becomes synergistic and you get a much amplified response in that. So part of my response to Gareth is he's absolutely right. I'm going to punch. He's absolutely right that we're oversimplifying it. My approach to this is we're adding layers. So we need to understand this, then we need to understand it in light of combination therapies. We've done studies where we've taken cells and said, okay, you've got an expression pattern that says you have a response, but 5% of the cells didn't die. We then take that expression pattern and say, aha, you're going to work with an HDAC inhibitor, another inhibitor, and then we add the combination to the cells and 100% of the cells will die. So these are all experimental approaches to try to understand the individual components and better predictions of how the combinations are going to be working. And as Gareth said, the problem with that is that you now have so many, the good news for myeloma patients is there are a lot of choices out there. The bad news from the research standpoint is there are lots of small pockets of these, so it's hard to get the right samples that have a consistent kind of treatment to make those kind of predictions. But we're working on it.
For me, reassessment annually is an important feature of managing patients. So you can't do it every other month. And so, you monitor the MRD status during the year in the blood. Then annually, we would try and do a PET CT or a MRI and match that with a bone marrow. So as you assess all components of the disease, it's perfectly possible to relapse with a focal lesion in one part of your body and to miss it if you look at the other. So that's our approach, which is mitigated on living in the south, patients being a long way away. You can then assure them that in the next year their actuarial chances of relapse are very, very low, and so then there's a degree of security. So that's the reason we do it. No. The interesting question is, so does smoldering myeloma exist? Okay, so that's where I would come from. Muggers, clearly a benign disease, 3% of people over the age of 55 to 60 have it, doesn't do them any damage, sit there, you watch it. Myeloma, you leave it within a certain period of time, it's going to become more aggressive, you should treat it. What smoldering myeloma is a construct to just to describe people that don't fit into either of those buckets. So as we understand more, if we could, take people with smolderers and say, you're going to behave like a muggus, go in the muggus bucket, you're going to behave like myeloma, go in the myeloma bucket, that would be a good thing. And I think that's what Ravi said. Currently, don't bother. I had such bad vibes with it. So like I got a guy from Seattle, clearly needs some different form of treatment, sent him to Boston. He went there, waited for 6 months, didn't get a slot, time goes on. And so the phase 1 component of these things are just about, coming to an end, stroke, coming to a new start. But in about 6 months' time, when the phase 2 components come into action, that's when you should be asking about how do you get into one of those studies. But no, it's an experiment currently. It's not necessarily a good treatment at this stage. So the NCI had a meeting in Washington at the beginning of the week to look at that kind of question, and so they're going to fund some research, but currently there's little research looking at that as a question. But if you see the challenge being, so like a myeloma cell is a very distinct cell, so what you need to do is understand why that's different to another cell, and then make drugs that target those biological differences, because then you have a differential sensitivity between your normal cells and the cancer cells. And so the clear feature of myeloma is that it produces the M spike. So if you could understand how that's carried out in the cell, you could mess with that process and kill plasma cells preferentially. And largely, that's what Revlimid and pomalidomide do, and it's what Velcade, carfilzomib, and ixazomib do. They affect plasma cell biology, which is why they've been so good.
There is another point at which people can get into fistfights at meetings, and that is defining what we refer to as the cancer stem cell. That is, what is the cell in which those lesions have occurred, and has that cell now progressed to the plasma cell that you see in the marrow, or is there a small amount of that cell that keeps populating the big population you're seeing? And so one of the dangers is you're using therapies to kill all the plasma cells, but you aren't necessarily killing the prime actor. Now, the debate, and unfortunately not a good answer, it is a debate in the field to say what is a good definition of a myeloma stem cell. And there have been arguments about what defines it, what are the biomarkers that define it, how do you define it. If you look at people who undergo therapy and then there's a resistant population coming out, there's sometimes certain characteristics of that look like it's a less differentiated cell that may be now reemerging and repopulating those plasma cells. The best I can tell you is that it's a debatable topic, and people are looking at that continually, because it could represent an undefined target of therapy, and we better define it.
The answer is it's not inherited, and your kids aren't at risk. And so I've done lots of work on it, and it's a kind of lottery, but there's no direct familial inheritance, so you should sleep soundly and not worry about them.
Okay, so when I tell patients about the idea of the genetic lottery, if you will, and what causes the features or the traits that define you and or disease, think about where the genetics is coming from. You inherit it from your mom and dad. We heard that inheritance is probably not playing a direct role in myeloma. The ability to repair DNA may have slightly different values in different people. So people who can't repair DNA damage might be a little bit more risk. The second component of genetics is what you do to yourself. If you smoke, if you obesity, what you eat can have an impact. And in fact, there are components in your environment that can change your DNA sequence. And if it changes it in an unlucky position, that can lead to that. The third, which is the hardest thing to accept, is imagine that every cell in your blood system, or every cell that defines you at some point, had to replicate 3 billion base pairs and pass it on to the next cell, and pass it on to the next cell. That replication, fortunately, is really accurate, but it's not perfect. And every once in a while it makes mistakes. And so there is a bit of this lottery system that's going on, that your exposures can impact your DNA sequences, the replication errors can impact that, and the ability to repair those errors might have a slight influence. None of those are really satisfactory answers to somebody that answer the question, why me? The other component of that is the cells are at risk because, as I said, immunoglobulin genes that they produce in those cells undergo chromosomal breaks and rejoins as part of the normal process. That's why those cells in myeloma are probably more prone than other cancers to developing these kinds of translocations, because the cell inherently is breaking and rejoining a chromosome as part of its normal function. When it does it as an error, it sets up these kind of translocations.
So again, we know that there are VA benefits for exposure to like Agent Orange and other known toxins. I think that certainly the Veterans Affairs has got programs that are directed towards cancer and research. I can't say specifically that I know of anything specifically in terms of going on in risk for myeloma for people who were exposed to certain agents in Iraq. What we do is when such a situation arises where a patient does tell us that they've been in the military, and we do ask them to go and speak to the Veterans Affairs Administration and ask them what benefit they are eligible for, and we do tell them that they're more likely to be eligible for benefits, especially if they're Vietnam War veterans. But that is something that, again, we don't unfortunately know the intricacies of.
Okay, but then you are talking, but the military is aware, because they do have on their website multiple myeloma.
Oh, definitely.
But it goes back to World War II.
Definitely.
World War II, Vietnam, Korea, and not anything ongoing right now.
Yeah, I unfortunately would not be able to say what efforts that they have ongoing for people in current war theaters as to what toxins they're employing, which could have exposure. I know that the Department of Defense and the Veterans Affairs does have a research budget. How much of it is being expended towards looking at myeloma, fortunately can't say.
So it goes that there are 18 genes that predispose people to developing myeloma, 18 out of 30,000, so very few. 7 or 8 of those validate in a black population, and it is quite true and clear that blacks have a higher risk than whites. The risk, it turns out, isn't in the change from MUGUS to myeloma. It's at the risk of developing myeloma or MUGUS. And the incidence rates seem to go up earlier in blacks than they do in whites. And so it's a clear issue of disparity in healthcare, and that's what the meeting in Washington was about. There's going to be a call for grants to look into this next year sometime. So I think it's good that government have recognized it, because it is about one of the only clues that we have as to why there's a genetic contribution to myeloma, and so it's not before time that it's being addressed.
One of the other things one has to keep in mind is the full picture of the risk factors. So we know, for example, that obesity gives you an increased risk, a couple-fold increased risk for developing a number of malignancies, including myeloma. We also know that in the African community, compared to other communities, there's a higher incidence of obesity. So one has to look at the confounding factors in that in order to really do the study appropriately, to make sure you're not fooling yourself into thinking there is an inherent genetic risk as opposed to other factors that might contribute to that increased risk, increased frequency. Well, in terms of gene editing is a really exciting field now with CRISPR and the ability to target specific genes. And one could imagine part of your question is if I can identify a mutation and I can genetically edit the mutation out, I've got it figured out. The problem is that most of the gene editing right now is not highly efficient. It doesn't hit every cell that it's supposed to hit. So you will always have a low frequency of correction in the background of a high frequency of misses in the gene editing. That doesn't mean in the future, futuristic, it won't get better, particularly as we get vectors like viruses that can have better efficiency. But at the moment, the efficiency of those corrections I don't think are sufficient to provide that kind of correction. The second question, artificial intelligence. One of the things that I have found the most useful is I had a recent postdoc who was really good at computational science and using various computational learning methods. So the computer actually runs through the data and it does some learning on its own on that. Admittedly, the one thing I will tell people is the people that I work with, I hope know more than I do to get major advances. I certainly think that we are now in an age where the data sets are becoming larger and larger and larger, and looking at a data set no longer is the way to do it. You have to have computational programming and artificial intelligence to kind of learn the process. So I think there are a lot of these national databases at NCI, NIH, and the like that are collecting these large data sets and basically challenging people. Use it. Find ways to develop computational approaches, including artificial intelligence, to wade through that large database. So there are some real proposals out there to do that.
And to answer your question as to do you work with Silicon Valley, I think each institution has its projects that they work with, even vendors outside of the institution. I think that, again, you've learned about all these mutations, but the fact is that probably the next level is going to come from some of these AI techniques where these individual mutations, that's what we're focused on right now. But how they work in synchrony, is what we need to figure out, I think, to get to the next level. And there, yes, artificial intelligence tools will be important. We've been working with a couple of vendors which have their proprietary technology to try to predict for how patients are going to respond to drugs, not just based on patient has a KRAS mutation or a BRAF mutation, but to put the entire sequencing into a computer, which they have proprietary algorithms that then they say, okay, these mutations, this patient has 10 mutations, and this perturbs the cell in these many ways, and can you then come up with a unifying force to try to target the disease? But these are still requiring validation. There are companies out there doing it, but I think they're not ready for prime time. But yes, we and others have also been working with such companies.
Follow up on what Ravi said, because I think it's really important. So 1300 is about the biggest set of mutational data that you can put together, okay? It's pathetic. Big data involves thousands and thousands, hundreds of thousands of data sets. And so until we start to get a way to assemble more mutational data or epigenetic data, these big data approaches are kind of like aimless hand waving, because I mean they're so small, the sets. And so encouraging people to get the genetic testing, moving forward with it, getting more data, that's what you're talking about. And that's really what is within our reach, is to assemble large patient data sets with DNA fully annotated, and then to use those going forward into the future as we have better technology. So it's crucial. So there are a number of kind of risk criteria that people have tried to use. All of them very imperfect, I would say. So the Spanish flow cytometry approach is not really much use in the clinic. It's hard to imagine what the ratio of two light chain values is and what it means biologically and why you should use that to treat people. We had a go using some gene expression profiling and came up with a GP4 score that predicted the risk of progression within an 18-month period. But they're all imperfect. And I think it's a discussion between the patient and the doctor, because it's the patients should be inputting into this decision making, and it's all a balance of risks and benefits. And if the patient feels there's a benefit for treatment, I'm inclined to go with them. And if the patient feels they don't want to be treated and want to be watched and take the risks that approach entails, then I'm inclined to go with that. But it's imperfect, and it's the real example where interacting with the patient is the most important thing.
That's a wonderful way to end the morning session.